point, we can make a start. Good afternoon, everybody, and welcome to today's webinar. My name is Ginevra Papi. I am a communications trainee at the Association of European Cancer Leagues, also known as ECL, and I'll be your host and moderator for today. This webinar is part of a series offered by ECL Secretariat and our Youth Ambassador group, which focuses on specific messages of the European Code Against Cancer. With me today from ECL Secretariat, I have David Ricci, Senior Cancer Control Officer, and Janet Raycheva, who's our Youth Ambassador for Bulgaria. I hope you are all prepared and excited to learn more about cervical cancer prevention and elimination, as much as I am. And today's webinar is co-hosted with the International Agency for Research on Cancer, IARC, and we are delighted to be having a presentation from Dr. Partha Basu. In terms of the agenda for this webinar, Janet will start off by giving you an overview of our Youth Ambassador program and the European Code Against Cancer. This will be followed by a presentation from Dr. Basu, which will last about 30 minutes. And after that, we're going to have a Q&A session and a short quiz to test your memory and knowledge of what you've learned today. And we will wrap up with some concluding remarks from David from our Secretariat. Before we get started, I'd just like to go over a few housekeeping items. So in order to ask a question, please type into the chat function and make sure that your question has been addressed to all panelists and attendees, so everybody can see it. And please feel free to ask questions throughout the webinar. You don't have to wait until the Q&A session, and you will be able to also ask questions anonymously. After the webinar is over, you will see a sign directing you towards a short survey. We really value your feedback, and we would like to encourage you to just take a couple of minutes to answer the questions. That will be great. And just a reminder that we are going to make the recording of this webinar and the slides available to you all after the webinar. They will be uploaded to our website, and we'll send you a thank you email with a link. Okay, now the logistics are covered. I want to take a second to introduce our first speaker, Janet Raycheva. Janet is a medical oncology resident doctor in Bulgaria, and her experience at ECL started at the very beginning, back in 2015, when the group of the Youth Ambassadors for the Code Against Cancer was formed. And Janet has been really active. She's been involved in many events and research activities related to medical oncology and cancer prevention. And her goal as a Youth Ambassador for Bulgaria is to accelerate the implementation of cancer screening programs at the national level. So without further ado, let me hand over to Janet.
Hello. Thank you, Ginevra, for the very great introduction. Hello, everyone. First, I would like to thank you for the invitation to be part of this amazing webinar. And I would like to introduce our job as Youth Ambassadors. So as Ginevra already mentioned, our group was created in 2015, and we started as just very few people across Europe, mainly students. And further with the years, our activities became bigger and more global. So our main aim is to work on the dissemination of the European Code Against Cancer, which is basically 12 recommendations that help us in the everyday life to save ourselves from getting cancer somehow. We are basically trying to promote healthy lifestyle, including avoiding the bad habits, like to avoid smoking and to reduce the alcohol consumption. And without any further words, I would like to share with you one amazing video that explain very well these 12 recommendations that help to reduce your cancer risk in the everyday life. So just a second. So, as I already mentioned, this video provides a very good overview on how to reduce our cancer risk. And as I mentioned at the very beginning, our activities weren't that many when we started, but I would like to share with you also in 2018 very briefly an overview of about the activities of the Youth Ambassadors on European level. You see here the map of the impact with different activities in the previous year. All this information, you can find it on the website of the Association of European Cancer Leagues. And as you know, as you already seen, number 11 and number 12 of the 12 recommendations are related to regular vaccinations, especially against HPV for girls and against hepatitis B. Also to go regularly on and to visit the screening programs that are organized in our countries. So I would like right now to continue with the presentation of Dr. Partha Basu, who can share with us very important information regarding HPV vaccination and infection and how to prevent cancer. Thank
Great.
you.
Thank you very much, Janet, for this comprehensive overview of our Youth Ambassadors activities. And just allow me to introduce our keynote speaker, Dr. Basu, Partha Basu. Dr. Basu is the head of a screening group at the IARC since March 2015. Prior to joining IARC, he practiced gynecological oncology for 20 years and served as consultant to the Ministries of Health of various South Asian countries and as well as the United Nations. Dr. Basu has over 80 publications in international peer-reviewed journals and authored 22 books and chapters, as well as contributed to various WHO guidelines. His research interests include new strategies for control of non-communicable diseases, cancer screening programs performance, novel treatment methods for cervical precancers, and HPV vaccines. So he's the perfect candidate and expert to go through the messages 11 and 12 of the European Code Against Cancer. Dr. Basu, the floor is yours.
Thank you so much, Geneva, for the very kind introduction. And good afternoon, good evening to all of you. At the outset, I must thank the Association of European Cancer Leagues for giving me the opportunity to address this webinar. As Janet has explained, that the European Code Against Cancer is essentially a set of evidence-based recommendations to reduce the risk of cancers at the individual level. And among these 12 recommendations, there are 2 recommendations that are essentially targeted towards reducing the burden of cervical cancer. In fact, cervical cancer is unique because there are 2 very, very effective strategies to prevent this cancer. And today we are at a stage when we are actually thinking of eliminating this cancer. Now, to give you the definition of elimination, it is a certain, you do certain interventions, and because of those interventions, the burden of the disease comes down to a level when it is no longer considered as a public health problem. And we have seen over the last few decades, several of the diseases that are listed in the table here, they are almost disappearing from Europe, from Northern America. And this has happened because of very effective vaccines against certain infections. So that brings us to the question, how does cervical cancer kind of link with these infections? And cervical cancer is a cancer that is caused by an infection. In the year 1995, the International Agency for Research on Cancer, it accepted that the human papillomavirus is the necessary cause for cervical cancer. The word necessary is very, very important, because we know there are several important causes of cancer. Say, for example, lung cancer is caused by smoking. But then somebody who has not smoked in his or her life can still get lung cancer. So smoking is an important cause of lung cancer, but not necessary cause. To say necessary cause, we have to show that without this viral infection, there cannot be that particular cancer. And that we have established for cervical cancer. And we know that without human papillomavirus infection, there will be no cervical cancer. And this is based on very rigorous evidence that was collected by the international agency through large multi-centric trials. As you can see in this map, we have shown the different countries from which the tissues were collected from women who had cervical cancer. And we looked at the human papillomavirus presence in those cervical tissues. And at the same time, we collected tissues from normal women who didn't have any cervical cancer. And then we compared the prevalence of human papillomavirus. And as you can see in this table, these studies were done in two phases. In the first phase, we involved 9 countries, and we collected large number of cases and then also controls. And then when we tested them for human papillomavirus, we found that those women who have cervical cancer, they have more than 90% of them have a presence of human papillomavirus in the cervical tissue, whereas those who do not have cervical cancer, 13.4% of them, they had HPV presence in the cervical tissue. In the second phase, when we used a better assay, better analytical system, we saw that this proportion actually goes up to 97%. In fact, following this study, we did further analysis with better assays, and we demonstrated that 99% of the cervical cancers, they have presence of human papillomavirus in them. And based on that, when we look at the risk or the strength of association between the agent and the cancer, we come up with this kind of result. As you can see in this slide, a smoker has 10 times to a risk of having lung cancer as compared to a non-smoker. A person who has hepatitis C virus infection has 20 times higher chance of having liver cancer as compared to somebody who does not have the hepatitis C infection. But then somebody having a persistent infection with human papillomavirus has 100 times higher risk of having cervical cancer. And there is a particular type of HPV, which we call HPV 16. The risk of or the association is even much more stronger for this particular HPV type with cervical cancer. So now we know that it is not only cervical cancer that is associated with human papillomavirus infection. In women, there are several other cancers, like cancers of the anus, cancer of the vagina, vulva, pharynx, has been linked to the human papillomavirus. In men, of course, the total quantum of disease is less because men don't get cervical cancer. But then in men, the oropharyngeal cancer is a major chunk of cancer which is associated with the human papillomavirus infection. And of course, men can also have anal cancer and penile cancer because of the human papillomavirus infection. So when we discuss prevention of cervical cancer, it is not prevention of cervical cancer alone through the vaccination, but then also prevention of several other important cancers as well. Now, if we look at this virus a little bit in more details, the human papillomavirus, there are more than 150 types now identified, and they are essentially divided into two classes. One class is the cutaneous type of virus, which is really not of a problem because it just causes some warty lesions in the skin. But we are more concerned with the mucosal type of the virus, which are again divided into two types. There are certain types which we call non-oncogenic, called HPV 6 and 11. This HPV 6 and 11, they do not cause cancer, but then they are responsible for a very, very bothersome disease, which we call genital warts. And then also in the newborn babies, it can cause papillomatosis of the larynx. On the other hand, the 15 or 17 high-risk types, which we call also oncogenic types, they are actually responsible for the different cancers which are the human papillomavirus infection. And the risk differs with the type of virus, HPV virus. HPV 16 is the most common and then most oncogenic and is responsible for 65 to 70% of the cervical cancers. HPV 16 and 18 together, they are responsible for about 70% of the cervical cancers. And the top 5 HPV oncogenic types, they are responsible for 80% of the cervical cancers. It is important for us to know this information because that tells us how much protection can we expect out of the HPV vaccine, which is essentially targeting HPV 16 and HPV 18. I will come to that later. Now, the human papillomavirus infection, it's a very common, it's very ubiquitous infection. A woman or a man has 80% chance of getting this infection in his or her lifetime, provided he or she is sexually active. In this chart, we are showing from 2 different studies the risk of acquisition of human papillomavirus infection in young females and males who have just started the sexual activities. As you can see, in the females, over the next 2 years of starting their sexual life, the 60% of them, they can get HPV infection. For men, about 40% of them, they can get HPV infection. But then the good news is that more than 90% of these males or females who get the HPV infection, they will clear the infection because of natural immunity in the body. It's only a few select women who we still do not know exactly why. There are certain other factors, but then they cannot clear the infection, and then they go on to have persistent infection with the human papillomavirus. And these are the women who go on to develop cervical neoplasias. The cervical neoplasias, they start with a condition which we call precancer. They are also known as cervical intraepithelial neoplasia. If we can detect the disease at precancer stage and treat it, then again, these women will not develop cervical cancer. But then if the precancer is not detected, not treated, maybe another 10 years or 15 years down the line, the woman will develop cervical cancer. So because of this natural history of the disease, we have 2 wonderful opportunities to prevent this cancer. As you can see here, the HPV infection initiates almost at the same time as the girl or the woman becomes sexually active, and there is a peak and it comes down. So if we have to vaccinate, ideally we should vaccinate before the girl is exposed to the HPV infection. That means it's a prophylactic vaccine targeted to young girls before they start their sexual life. So that's why in most countries, the primary target age for the HPV vaccine is 9 to 15 years. And then again, the precancers, which are caused by the persistent HPV infection, starts appearing around the age of 30 years. And it peaks around the age of 40 years. So That's why the screening recommendations you'll see in most countries, it is to initiate cervical cancer screening between 25 to 30 years of age. Before that, it is mostly transient HPV infection, which does not have much of value. But then starting from 30 years, we initiate the screening, or 25 years, we initiate the screening, we detect the disease at precancer stage, we treat it, and we prevent cervical cancer. So there are two different but then very effective ways to prevent this cancer. Now let us look at the vaccine a little bit in more details. Currently, there are 3 different types of vaccines available against human papillomavirus. One is called quadrivalent. It is quadrivalent because it targets 4 different HPV types. It targets type 16 and type 18, which are responsible for about 70% of the cervical cancers. It also targets HPV 6 and 11, which are responsible for nearly 90% of the genital warts. And then the bivalent vaccine, it targets HPV 16 and HPV 18 only. Now, the vaccines, though they target the HPV 16 and 18, there is something called cross protection. That means the other HPV types, which are genetically related to these 2 types, the vaccine also protects against them. So the level of protection, it increases from 70% to around 80%, even though the vaccine is targeting only type 16 and type 18, which are responsible for 65 to 70% of the cervical cancers. And now there is a new another vaccine available that's called nonavalent vaccine that is targeting 9 different HPV types, of which 7 are the oncogenic or the cancer-causing types. Now, this vaccine has been, the acceptance of the vaccine globally has been tremendous as compared to the other vaccines. If we see that this particular vaccine was licensed around 2006, and then within the next 15 years, you can see that half of the world has accepted the vaccine and then introduced the vaccine in the national immunization program. But then there is a catch here. If the countries which have the highest burden of cervical cancer, unfortunately, they are being deprived of getting the vaccine. So if you look at sub-Saharan Africa, if you look at 2 countries like India and China, we still do not have the vaccine in these countries, though they contribute to the to huge number of cervical cancer incidents and cervical cancer cases and cervical cancer deaths globally. We have seen that these vaccines have shown wonderful results in the randomized controlled trials. But then now, after several years of use in the real national programs, now we have data coming from the real life programs to show that the vaccines are effective and the vaccines are safe. Australia was one of the very first countries to introduce the vaccine in 2007. And you can see the earliest effect of the vaccine is seen on genital wart. As you can see in this graph here, this is looking at the genital wart prevalence in the young women who are attending the genitourinary clinics in one particular province in Australia. And you can see, following the introduction of the vaccine, there is a significant drop in the genital warts. And in Australia, they use the quadrivalent vaccine, which is essentially targeting the prevention of genital warts. And what was very interesting was that at that time, though the boys were not vaccinated against human papillomavirus, this study demonstrated that even the boys or the young men, they also had a significant reduction in the genital warts. Now, one can say that this can be because of some other coincident factors. So they also looked into what happens in the men having sex with men. And as you can see that the graph for the men having sex with men, it is a flat one. So this vaccine is not only protecting the girls or the young women against genital wart, but it is also protecting the young men against genital warts due to a phenomenon which we call herd immunity. It is essentially the vaccine is causing a reduction in the total infection burden in the community. And so everybody in the community is being protected. So, and then there are different ways we look at the effectiveness of this vaccine. One of the way we look at the effectiveness is looking at the prevalence of the vaccine targeted infections in the community. So this is a study which was done in England. UK introduced the vaccine quite early. They introduced the Bivalent vaccine. And as you can see, within a few years of introduction, there was a significant drop in HPV 16 and or HPV 18 infection, particularly in the girls or women who received the vaccine at a younger age. So this is the dotted line here is the reduction in the youngest age cohort. And as we look at the higher age cohorts, we can see the reduction, but then the reduction is not that much. We can see the reduction in the cross-protecting types as well. But then when we look at the HPV types, which are not at all protected by the vaccine, we can see the straight line. Again, proving that the reduction is due to the vaccination and not due to some coincident factor. And again, a very important lesson from this particular study is that the vaccine works best if it can be given at the younger age of at younger age. It is effective at older age, but by the time the girls are already exposed, they're already infected, so the protection is much less. And then this is a very, very important study results which came out of Denmark. Again, within a few years of introduction of the vaccine, they observed a significant drop in the biopsy-proved the prevalence of cervical intraepithelial neoplasia. So the first white one is the reduction in CIN3 prevalence. There was 80% reduction in CIN3 prevalence in the vaccinated as compared to the age-matched unvaccinated women. 73% reduction in CIN2 or CIN3. And also important was that 60% reduction was seen in the cytological abnormalities of the women who are undergoing screening. This is also very important. Reducing the cervical, cytological abnormalities indicate that there is less burden on the colposcopy services, less burden on the women to visit the colposcopy services. And then again, in this study, we see the same pattern as we have seen in England, that the protection is there among the women who received the vaccine at an older age, but then the level of protection is less as compared to the younger women. And there are always skeptics of this particular vaccine, and they say, oh, this vaccine has not yet shown to protect against cervical cancer. First thing we need to understand is that cervical cancer takes many, many years to appear. Second thing is that no ethics committee will allow us to do any study where women are being followed up to reach the stage of cervical cancer. But then there are certain data which are already available from countries like Finland. In Finland, a large number of women they participated in the randomized control studies evaluating the bivalent or the quadrivalent vaccines. So once the studies were over, all these women were linked with the cancer registry and followed up over the years. And along with them, an age-matched control was selected, and they were also followed up over the years using the same registry. And now you can see, though it is very early data, and we don't expect too many cancers to happen in this relatively young population, but then still you can see that HPV-related cancers have already started appearing among the unvaccinated age-matched controls, whereas in the vaccinated girls or women, we have not yet seen any cervical cancer. The safety is a major issue with any vaccine, and this is one of the most heavily scrutinized vaccine. There are randomized control studies to prove that the vaccine is safe. There are meta-analysis of randomized studies and then Cochrane reviews to show that the vaccines are safe. And as you can see, there are several international and national organizations which are continuously monitoring the safety of the vaccine. Till now, the vaccine has been found to be very safe, and none of the organizations which are listed here have changed their recommendation for the safety of the vaccine. The only major side effect which is found is the anaphylactic reactions, which is found in almost all vaccines. And the rate of anaphylaxis reaction seen in the vaccinated girls or boys is, as you can see, 1.3 per 1 million doses. But then there are always the naysayers for the vaccine. There are conspiracy theories, and there are, all the time in the social media, there are things against the vaccine, and things become more complicated when the national government does not respond in a responsible way. So this is a very classic example of this is in Japan. In Japan, they introduced the vaccine, and as you can see here in the graph, the vaccination program was going on very well for 5 years with reasonably high coverage of the girls. And then there were few reports in the media of the girls having, some of the girls having joint pain and convulsions. And these girls were made to come on the television, and then they told their story. What was unfortunate is the government, instead of looking at the problem in a more objective way, being more empathetic to the girls who are suffering, they simply came out with a recommendation which said that, okay, we keep the vaccine, we don't withdraw the vaccine from the program, but then we are not proactively recommending it, which is a very, very ambiguous statement. And this created further confusion. And now, as you can see, the vaccine coverage in Japan is extremely low. And similar things have happened in many parts of the world, including India and Colombia and Brazil. So we need to understand that these women or these girls, they have a certain background risk of having certain diseases. One of them is called complex regional pain syndrome, which essentially the girls in Japan, they were having. It is nothing new. It happens to young girls. It happens because of any kind of minor trauma or even any kind of injection. And then the girls suffer from the local pain, paresthesia, or very highly sensitive skin. And then also there is a component of stress related, there is a stress related component. So it happens. What is important for us to see is that whether the background incidence rate of this particular disease goes up after vaccination as compared to what has been reported before vaccination, or which has been reported in the unvaccinated girls or women. Until now, none of these diseases or the new onset chronic diseases or the autoimmune diseases have found to have higher background rate in the vaccinated as compared to the unvaccinated women. So the vaccine safety issue, the vaccine is still considered very safe vaccine. But then if we look at Europe, again, the story is not that encouraging. As you can see, some of the countries, they have done excellent, and then they're having persistent, only high coverage of the vaccine. But some of the countries, they're still lagging behind. So it is very important to ensure that the governments, they invest more in creating awareness, and they become more responsive to these rumors or issues that are coming up in the social media. Now let us take the story to the other preventive intervention, that is cervical cancer screening. A lot has happened over the last decade to bring a paradigm change in cervical cancer screening as well. Because of the very strong association of human papillomavirus to cervical neoplasias, the HPV detection has been tested as a cervical cancer screening test. And as you can see in this graph, that there have been studies all across the world, including many low and middle income countries, where it has been very well established that the HPV is the detection tests are the most sensitive cervical cancer screening tests, much better than the cervical cytology, which has an average sensitivity of about 50 to 60%. And it has several other advantages. For example, it is an objective test. That means you don't need a very highly trained provider to come up with the results. And the machine can do it in a throughput way. And another big advantage is that because of the very high sensitivity, the negative predictive value of HPV detection test is very high. Negative predictive value is the reassurance that we can give to a woman who is tested negative to the test that she does not have the disease. As you can see in this graph, this is the follow-up study of the women who were tested negative on cytology or on HPV test or on both cytology and HPV test. You can see those women who are negative on cytology at baseline, they keep developing the high-grade cervical precancers every year over the years. On the other hand, those who are negative on HPV test, as you can see, over the next 5 years, almost none of them develop high-grade cervical precancers and definitely not cervical cancers. So this allows us to expand the interval between screening to 5 years. No more screening every 2 years or 3 years. HPV detection-based screening can be done every 5 years. We evaluated the cervical cancer screening programs across the 28 European Union countries. And what is very important is the heterogeneity we see in terms of access to cervical cancer screening in Europe. Though Europe has always been in the forefront of ensuring cervical cancer screening and then implementing the programs, but still you can see the very different, the difference we see in terms of screening coverage of the women. In some of the countries, the screening coverage was less than 50% and even much less. And then there are certain quality indicators. One of the important quality indicator for cervical cancer screening is the participation rate. That means what proportion of the women invited participate in cervical cancer screening. And in Europe, the recommendation is that 70% of the women should participate in the screening program. And as you can see, the average we calculated, it is much less than the acceptable level. And in many of the countries, it is even significantly lower. So again, there is a huge importance of creating awareness and ensuring access to quality screening in the European countries. What is again worrying is that in many of the European countries recently, we are seeing a trend of increasing cervical cancer incidence in the youngest population between 25 to 35 years. As you can see in this particular graph, this dotted line is showing the trend in the youngest age cohort, which is really going up like what it was before the cervical cancer screening was introduced. You can see this graph is among the older women who have been screened properly. But then this is the graph which is the youngest women. Probably they are not having a screening as per recommendation and escaping the screening program and going on to develop more cervical cancer. So this is a worrying trend. Now, Australia, again, if we come back to Australia, is one country which can be considered as a showcase and probably is going to achieve elimination of cervical cancer within a very short time. So WHO accepted that if a country has the incidence of cervical cancer below 4 per 100,000 women, then that will be considered to have eliminated the disease. As you can see in Australia, because of implementing well-organized cervical cancer screening program with high coverage, they have already had the low cervical cancer incidence. They initiated the HPV vaccine in 2007, 2008. And this is going to show result, after about 15 to 20 years. And in the meantime, they have introduced HPV-based screening. And because of these two essentially very effective interventions, the modeling shows that within few years, it is going to be below, the incidence is going to be below 4 per 100,000 in Australia, with a significant drop in mortality as well. Now, one can argue that whether we can only go for vaccination and not go for very complex screening, will that help us to eliminate cervical cancer? Yes, theoretically that is possible. If you can see this modeling study, this is if we can introduce very high if we can implement very high coverage of screening as well as vaccination, we are expected to reach elimination globally around the 2060. So, for example, another 40 years from now. But if we only go for vaccination and ignore cervical cancer screening, that will take another 50 years to come down. By that time, 45 million women across the globe will get cervical cancer. So it is time that we need to act. We have to make sure that our women are protected from cervical cancer and our girls are protected from this deadly disease. Thank you very much.
Excellent. Thank you so much, Dr. Basu, for this concise yet comprehensive overview of cervical cancer prevention, and especially the call to action for elimination, which I found really interesting. And also personally, I really liked to talk about the safety of the vaccination and vaccination hesitancy, because I think it's a very timely topic. Great. So I think we're going to have 5 to 10 minutes for questions. So the floor is now open for questions, thoughts, comments. Please make sure you type in your questions into the chat function and address them to all panelists and attendees. And Anna Meyer, our Youth Ambassador for Austria, already asked the questions. So I'm going to quickly read it out and ask Dr. Basu to reply to the questions. So Anna was wondering how come that in Italy vaccination uptake rates are quite high when actually there's been a move towards supporting anti-vax movements. If you could answer that.
Yeah. Things are changing over time globally, and same is in Europe. Many of the countries, they initiated their programs with a very high coverage, and things happened, and then that affected the vaccination program. And then, as I said, the responsiveness of the government, and then the scientific community, whether they could come forward on time and then come out with a convincing argument in favor of the vaccine, made all the differences. So, and maybe if the graph I showed to you, it was from a study in 2016. If something recent might have happened, as we have seen, it has happened in some of the European countries, may have affected the vaccination coverage as well. But then it is for us to understand that this vaccine safety has been established through very rigorous, scientific arguments, and it has been found to be very effective.
Yeah, of course, it makes sense. And I personally, I'm from Italy, so I know then when I was at the age range where I had to get the vaccinations, it was pretty popular. So I can see how the data refers to previous years, probably. Great. So does people have any other question? Please just feel free to put it in the chat. Otherwise, I don't know if Janet has any questions to pose to Dr. Basu in the meantime.
So I'm actually having maybe some.
Yeah.
Like to have. What do you think if it's possible to implement like an obligatory HPV vaccination to make it mandatory on a European level in general, not only on national countries? Do you think that it's possible to influence the national government to make it somehow? And to make it all the European countries equal regarding the HPV vaccination?
There are two things. Obligatory to the country, the national immunization program to provide the vaccine, and obligatory for the girls to go for the vaccine. Let me take the second issue. In the United States, they tried to do that and that backfired. We have to respect the autonomy of every individual, even for the young children. So my point is that no obligatory vaccination for the girls or even for the boys is not the way to go forward. But then, yes, now with the WHO call for elimination for cervical cancer, there will be a lot of, I would say, pressure on the governments to look at the effective implementation of cervical screening as well as the HPV vaccination program. I mean, that is the major, objective of the WHO initiative for cervical cancer elimination, to make sure that the governments, they understand the importance and go ahead.
Thank you.
Perfect.
And
Excellent.
yeah. I think I may have a second question. Because you mentioned that it's necessary to have an HPV infection in order to develop cervical cancer, but what if the girl is already vaccinated? Is it still possible to get cervical cancer? Is there any data about it?
Yes, as I said, this is a prophylactic vaccine. That means if the girl can have the vaccine before she gets the sexually active, and before she gets exposed to HPV infection, she is very highly protected. There is something called breakthrough infection or breakthrough disease. That means somebody has, as you said, that somebody who has had a vaccine gets cervical cancer. Till now, that breakthrough disease has not yet been reported. So we are still, we still have to keep, tab on the programs, and then the programs need to ensure surveillance and report their outcomes from time to time, so we can understand not only the breakthrough of the breakthrough of the vaccine, but also how long this vaccine can protect. At this present moment, we have data beyond 10 years or 15 years to say that it is giving protection. We don't need any booster. But whether 20 years or 30 years down the line, the girls will require a booster, we still do not know. So that is why we should keep our eyes open and then keep collecting the information from the programs.
Thank you very much.
Great, perfect. And I think we've got a couple more questions. Okay, great. The first one is, when resources are actually not enough, what should one country prioritize, vaccination or screening?
That's a very good question. Okay, let us understand the reality. The reality is cervical cancer screening is a very, very complex program. Even when we look at the introduction of the vaccine and the introduction of cervical cancer screening in different low and middle income countries, we have seen that the countries failing miserably to introduce cervical cancer screening have done very well in terms of achieving high coverage of the girls to the vaccine and ensuring access to the girls. In a way, the introduction of the vaccination is relatively easier for the countries. But then, as I said in my talk, that there are again millions of women who are at risk of having cervical cancer. We need to do something to protect them. And that is why cervical cancer screening is also required. So for the governments, both the perspectives should be looked at, vaccination as well as the screening. And one good news is that at IARC, we are doing a very large study where we are looking at the efficacy of a single dose of this vaccine. Until now, our early data shows that maybe even a single dose of the vaccine can be as protective as 2 doses or 3 doses of the vaccine. But then that's very early results. We still have to continue follow up. And if that happens, that will be an excellent news for the different low and middle income countries.
Excellent. Thank you so much for getting this rapid succession of questions. And I think we've got more, but we're really running out of time, and we really want to see if the memory of our attendees, how's the memory of our attendees, and we would like to launch the poll. So for who, please keep asking your question in the chat if you want, and I'll compile them and make sure that we answer to them. But for now, I will launch this short quiz. It's 9 questions. They will appear on your screen in a second, and Janet will read the questions out and we'll give you some time to reply. So I'm just going to launch a poll, yeah?
Okay, so let's start with the first question. And it's very simple. Is it possible to prevent cervical cancer? And the possible answers are yes, no, yes, and not sure. Should I proceed with the second one? Okay, let's go on. According to the WHO, what is the recommended age range for the HPV vaccine? 12 to 18, 8 to 16 years old, 9 to 14, or 12 to 24? Number 3, can males get cancer from HPV infection? Yes, no, or not sure. Number 4 is about the HPV serotypes. And you see here the lines with different oncogenic HPV types. Line A, 6, 8, 11, 33, and 45 are the high-risk HPV serotypes, or 16, 18, 31, 33, 45, or 16, 18, 21, 23, 7. Please remember the right serotypes. Question number 5. Which HPV-related cancer is most common in women? Cervical, anal, or oropharyngeal? Then we have which HPV-related cancer is most common in men? Anal, oropharyngeal, or pineal? We have an issue here.
Yeah, I think people, 3 people are answering to the questions right now. So we're just going to give some more time.
Yeah, maybe it's better.
For people who want to engage. For attendees, just let me know if through the chat if you are having any problems to see the quiz. It should have appeared on your screen, and you should be able to pick the option that you prefer. Yeah, okay, great.
Oh, good. Okay, so
I think some people are having issues.
Yeah, it seems so.
Yeah, I think some more.
See the quiz. Yeah.
I think just for attendees, you probably need to answer all the questions and then submit in order to be able for me to see your response. So just you fill in all the questions first and then you submit. Yeah, okay, so I think more and more people are replying. We've got 9 people engaging with the quiz. For those, I hope those that were mentioning in the chat that they can't see the quiz, maybe if you just have a look at the toolbar at the bottom, you should see probably a window that directs you to the poll. Okay, great. So
maybe bottom left.
Yeah, because I think I want to get a couple more questions from the attendees because we're getting many questions. I'm just gonna end the poll, and we won't reveal the correct answers now, but in the thank you email along with the recording and the slides, we're also gonna give you the report of the quiz. So thank you very much for taking part in the quiz. I'm just gonna end the poll. Great. Actually, I can share the results. Let me see. I think actually now everyone can see the results. It's quite nice. Yeah, it's not too bad. Most people got most of them right. That's great. Perfect. So I think we have 5 minutes left. I'm gonna just ask Dr. Basu to please answer a couple more questions. There was one which I found it really interesting. So what about boys? So we talk a lot about girls. So should they get vaccinated? And the programs, how are the programs in countries where also boys get vaccinated are going?
Yeah, that's a very good question. You know, the boys also need the vaccine because of two reasons. Number one, they themselves need protection against the cancers, as we discussed, the anal cancers, penile cancers, oropharyngeal cancers. Another very important thing is that, you know, if the boys are also vaccinated, the transmission of the infection in the community gets, you know, significantly reduced. And as a result, the level of protection against the all HPV related diseases, both in men as well as women, becomes very high. So that is the reason why many of the countries, even in Europe, are now actually going for vaccinating the boys. So yes, the boys also need the vaccine and they can benefit. But then for the countries, you know, it's a question again of priority. There is evidence that if we can vaccinate the girls and achieve a high coverage, that is going to be more cost effective, and that is also protecting the boys for because of the herd immunity. So that's why the priority is to vaccinate the girls, because the quantum of disease is much more in the girls because of the cervical cancer, because of the vulvovaginal cancer, and of course anal cancer and oropharyngeal cancer. But then boys can be considered if the country can afford to vaccinate the boys.
Perfect, excellent. And I think the last question, I think a couple of people were quite interested in knowing if you had any follow-up on the situation in Japan, and also the second one, if a question from Matthias. Do I understand correctly that is it worth advocating to switch to HPV screening, and would these be to subgroups or to the entire target group?
Both are very important questions. Yes, in Japan, unfortunately, things are remaining status quo. So that's there is no change in the policy of the government. There is no active no activities to improve the coverage, and then the coverage is still very low. And in fact, very worrying is, again, we have reported that in Japan, among the young women, the cervical cancer rate incidence is going up. And the second question was
sorry, yeah, I'm just gonna read it. Sorry, I'm just gonna read it out again. Is it worth advocating to switch to HPV screening, and
yes,
to subgroups or the entire target group?
No, HPV screening is meant for all, exactly as we have implemented cervical cancer screening based on cytology at some point of time. We can switch from cytology to HPV detection based screening for all the women. It is not meant for any targeted screening.
Great, perfect. Thank you very much. So I think we're getting towards the end of this webinar. And before signing off, I will let David close the webinar with some final remarks. Thank you very much to everyone for tuning in. Thank you very much to our speakers. It was truly great to have over, I think, 35 of you attend the webinar today. So I'm just gonna give the floor to David for some final remarks.
So thanks, Ginevra, for a really excellent hosting of the webinar. Thanks also to Dr. Basu for very graciously and kindly giving his time and making a really fantastic, concise and comprehensive, as Ginevra said, overview of this extremely important topic. And special thanks also to our youth ambassador from Bulgaria, Janet, who's been with us a long time, and we count on their support very actively. So thank you all. for participating. This is a really important topic for us because, as Dr. Basu outlined, this objective to have the elimination of cervical cancer is not just a slogan or a dream, it's an actual reality. And in this fantastic overview today, we've seen some evidence and data from the real world, from the scientific domain, about how this can really be achieved. And so this is justification not only for why this issue is prominent within the European Code Against Cancer through messages 11 and 12 on vaccination and screening, but we've also included it as ECL within the manifesto towards the next European elections for parliamentarians to support very actively, vocally, the call to action for cervical cancer elimination within Europe as well as globally too. So we should also think of this as we're primarily active within the European geographical region as an issue of also key and important global relevance. So once again, I'd like to thank you all for joining us today, the speakers and also very active participants too. We're sorry we couldn't get through to all your questions, but we'll try to address these in the follow-up of this webinar. As Ginevra said, the webinar has been recorded and the slides will be distributed afterwards along with a short survey. So we encourage you to keep in touch and to join us. And the important actor in all of this is, of course, IARC, the International Agency for Research on Cancer. So we should all be following and supporting behind them to join in this very important priority for the future. So thank you all for joining us, and we'll join you next time in our webinar. Thanks very much. Bye.
Thank you.
Thank you. Thank you.
Thank you. Thank you, Janet. Very good. Thank you. Bye. Bye.
Bye.